Good afternoon, everyone, and welcome to today's ACE webinar series. Today's session, From Data to Action, it's strengthening maternal newborn health systems through smarter data use and strategic partnership. My name is Chidera, and I will be your moderator for the next 95 minutes. On behalf of ACE Group, we are so delighted to have you join us today. Whether you're joining us from the ministry, as an implementing partner, or anywhere across the health sector, you belong in this conversation. Just a few housekeeping notes. Please note that this session is being recorded, and a summary will be shared with you all after this event. Please keep your microphones muted, and you will be invited when we want you to speak. Throughout this section, we encourage you all to please engage. Use the chat box to introduce yourself, where you're joining us from, as well as your organization. We have a packed agenda for you and a remarkable set of speakers. Let's get started. So before our speakers take the floor, I'm just trying to set the context for today's conversation. We live in an unprecedented data availability health era. And yet the persistent challenge is around whether we are using the data that we have to make decisions, and if the culture that we have available is actually translating into what we are supposed to do. This is exactly what we're unpacking today. And we have three exceptional speakers that use this data every day on the field. Our first speaker is Nanman Kankom, and he is a pharmacist and a health management consultant with over 6 years of experience in strengthening maternal healthcare delivery in Nigeria. He is also a manager at CEDA, and his work spans maternal, neonatal, and child health commodity access, supply chain strengthening, monitoring and evaluation, as well as data systems. All of these are oriented towards preventing postpartum hemorrhage and ensuring the rollout of global best practices at scale. Our second speaker is Dr. Zarami Buka. He is a public health specialist with over 15 years of experience leading maternal, newborn, and child health programs in Nigeria. He currently coordinates mortality surveillance, the maternal, prenatal, and child death surveillance response system across 10 states, and over 15 years of maternal and newborn health research projects. He holds a doctorate degree from the University of Maiduguri and across several universities as well, including the London School of Hygiene and Tropical Medicine, and also has an MBA with distinction from the Manchester Metropolitan University. Our third speaker today, but not the least, is Dr. Shamsuddin Yahaya. He is a consultant public health physician, academic, and a health system leader with extensive experience in public health administration, healthcare financing, and primary healthcare systems strengthening in Nigeria. And he is currently the executive secretary of the Ekiti State Primary Healthcare Agency. He spearheads strategic efforts to improve immunization coverages, optimize service delivery, and expand equitable access to essential maternal, newborn, and child services. You all should please join me in giving a warm round of applause to our speakers today. We are so glad to have you here. So we'll now be moving to the very heart of today's session, our case presentation. Each of our speakers will spend exactly 12 minutes to share a concrete example of how maternal and newborn health data informed decision, drove action, and even improved outcome. These are not just frameworks or models that have worked. These are also lived experiences from the field. We would now begin with Nanman Kangum first, presenting his slide on data to action. Dr. Nanman, the floor is yours.
Yes, thank you so much, Chidera, for the very warm welcome. It's really a pleasure to be here, and I'm delighted to be part of this group with such eminent speakers like Dr. Booker and Dr. Shamsuddin. But also thank you to ACE for setting up this timely discussion. I think it's a good one, and you guys are trusted partners in this journey for improving how we use data for action. So just as a bit of background, one of the biggest challenges in maternal health in Nigeria isn't that we lack data, but oftentimes we struggle to transform that data into decisions that would lead to improved outcomes. And today I'll be sharing two examples, one about how we use data to improve outcomes, the facilities, but also how we use data to inform actions on the policy level. So Nigeria contributes one of the highest number of maternal deaths in the globe. Please go to the previous slide. And in addition to some of the challenges around the poor capacity to provide adequate services, the lack of products that are needed to ensure women get the right kind of care. There's also challenges around using data that's generated as part of routine programming to inform decisions that would ultimately improve outcomes, especially in the myriad of interventions that are being rolled out on a daily basis. So the Smart Mothers project, at a time when we're scaling up to multiple states, working in over hundreds of facilities, to think about how can we create a model that would transform our routine programming data into data that we could use for action. So the next slide sort of lays out some of the various pieces of things we talked about. And the guiding principle really was ensuring that our data went beyond reporting to the donor, to the government where necessary, but also would be used to inform actions. And we thought about this carefully. So beyond collecting and analyzing data, what kind of evidence can we generate? What kind of actions can we take that would ensure that we were nimble, but also improving outcomes? And these pieces just ensure that we're not being reporters, but we're routinely reviewing data and then making decisions that could be acted upon. And like I said, I'll be speaking to two examples. So let's start with the service delivery. The project set out, on the next slide, the project set out to really roll out a comprehensive bond. Could you move to the next slide, please? Thank you. Yes. I'm one of the levers to health worker capacity to training and mentorship. But couldn't tell us, please go back, couldn't tell us what facilities needed support. Training couldn't tell us, alone couldn't tell us how performance was being tracked across multiple states, which facilities had poor outcomes. So we, through routine mentoring, supervisory visits, and case reviews where necessary, try to understand some of the ways we could then use the data we had to inform or make better decisions. Next slide. So just to provide a picture of what we collected, which a lot of people will be familiar with. So your routine data that's available in label and delivery registers, data from your pharmacy stock cards, patient case notes. Collecting all this information tell us monthly deliveries, availability of products, how these products were being used, and of course, set up systems, analyze it in a way that could be useful to whoever was looking at it. And then leveraging different platforms to routinely review and arrive at decisions. The next slide just speaks to some examples of how we did this, and really just a few examples. There's a lot I could speak to, but first, talking about commodities or medicines. Typically, we think of medicines, and the way we collect data around medicines around is the stock available? Is there a stock out? When was it delivered? How much stock do we have left? But however, as part of programming, we noticed that there was a situation where commodities were provided, however, they were not being utilized. And so that suggested we had a practice problem, not necessarily a supply problem. So double clicking into this helped us to understand what needed to be done in terms of just ensuring providers then knew how to use the tools. So that's through refresher trainings, through demonstrations, through follow-up visits as well. And in this specific example of a calibrated drip, we noticed an almost double increase utilization within a month of intervening. When you go beyond the facility as well, you take it from state level, we started to see as a program where PPH case fatality almost doubled in a very short period of time. So using data, we're able to pinpoint two states that were driving more than 50% of this increase. That also then led to some specific programmatic decisions around escalating advocacy, ensuring that the protocols and new guidelines were deployed, but also even increased facility engagement. And over a period of time, we then started to see that trend change with PPH cases then going down. Next slide, please. So all of these led to improved outcomes. We saw better state ownership because we're able to share data at different levels with different stakeholders, ultimately saving more lives. But it's important to point out and reiterate that the data alone did not lead to all of this. It was actions informed by the data that lead to all of this. So it's really ensuring that data goes beyond our routine reporting, but becoming a key management tool that can lead to improvements in clinical practice, strengthen accountability, and ultimately contributing to better outcomes. My second example is really on policy. When you think of policy and the cycle of how policies are adopted, research and analysis are some of the first steps. Policymakers often need local evidence before acting. So in 2020, when we started this project, the data showed that Nigeria needed to rethink the uterotonics we're using for PPH prevention. Oxytocin available was of poor quality. Stable capitocin had just been adopted globally as a new option for postpartum hemorrhage prevention, but had not yet been adopted in Nigeria. So as part of programming, next slide, we decided to conduct an implementation research that will generate the kind of evidence that will be useful to decision makers and policymakers in terms of recommendations for the country. So we tested the efficacy of the product, tested if it was acceptable to physicians, midwives, nurses, tested if it was safe, and the next slide sort of showed the kind of data we used. So through chart reviews, through health worker interviews, facility assessments, qualitative interviews that then showed us that yes, this product was acceptable, it would be feasible to roll it out in country, it was safe, and could be adopted across facilities. We then transformed all of this into policy briefs and recommendations, different stakeholders of the government, which then led to national adoption of stable capitocin as a uterotonic for PPH prevention. And I know that sort of summarizes what, but I think this slide here tries to capture what drives success for some of your interventions successfully. Partnerships are important. It's important that everyone sees the data and uses it as a level that would be useful to them. So in many ways, health workers, health facilities, even implementing partners are doing a lot of good work on the field, generating useful insights and intelligence that will be useful to government, for example, in terms of making new policy for an executive like Dr. Shamsuddin in terms of determining where resources should go to. Should we buy more products? Should we train more health workers? Should we employ more people? Should we upgrade the facility? So everyone needs to see the data, and partnership looks like government, of course, always being in front of the driver's seat, leading the agenda, leveraging different platforms for accountability. We have technical working groups everywhere. Those are the right kind of places to engage. As implementing partners, we definitely need to provide technical support where needed, where necessary, but also ensuring that there is this continuous feedback loop that ensures data drives action, and being consistent that way. So three things I'd want you to take away from my presentation. One is that we need to capture the right kind of data. So not just data to report, but data that would ultimately help us improve quality of care, improve outcomes. Two is that we need to strengthen accountability. And for this is really leveraging what exists, what platforms for accountability exist, ensure that everybody, all the stakeholders sees the data and can use it. Third is then ensuring that we integrate systems broadly. So we shouldn't think of data in silos where someone's collecting service delivery data, supply data, but something that brings everything together that will be useful for stakeholders at different levels to make informed decisions. So overall, our experience on the Smart Models project showed us that the challenge is rarely lack of data. It's rather creating systems that routinely review data, identify problems, assign actions, and follow through on implementation. And when that happens, data becomes more than information. It becomes a tool that can be used for improving outcomes. Thank you so much for listening, and I'm looking forward to the other presenters as well. Over.
Thank you so much, Nanman. I mean, this was a very powerful example across 7 states. The data didn't just show, or your findings didn't just show that training alone closed the gap. It also shows that data reviews as well as supervisory visits, reviewed exactly where and why this outcome differed. Thank you so much. So just riding on this, we'll be introducing our second speaker, Dr. Buka Zarami. Over to you, Doctor.
Yeah, thank you very much, Chidera, for the earlier very warm introduction. Once again, my name is Bukar Zarami. I'm a program manager with the Clinton Health Access Initiative, CHI. And over the past years, we have been working very closely with the Katsina State Primary Healthcare Agency in order to bridge MNH data gaps. And through that process, we're able to activate the Community-Based Health Management Information System, which is popularly known as the CBHMIS, generate community-level MNH data, and also use that data for decision-making in order to drive a reduction in maternal and newborn mortality. For this discussion today,
Hi, Dr. Zarami.
it's according to the World Health Organization report on maternal death, Nigeria accounts for about 28.5% of global burden of maternal mortality, even though our population is just around 200 million people. The average MMR is 512 per 100,000 live birth. However, we have significant disparity between the MMR in the northern part of the country as well as the other parts of the country. There are studies conducted to show that MMR in northern Nigeria is at least 2 to 3 times as high as what is obtainable as the national average. Another key feature for northern Nigeria, places like Katsina, about 84% of deliveries take place outside the health facility setting. When stakeholders like you and I want to make decisions to reduce mortality, we tend to focus more on the NDHS data or the DHIS2 data, and both of them have shortcomings. For the NDHS data, we only have the national average. We don't have state-specific MMR, and that becomes difficult in making decisions to drive reduction in mortality at the community level. At the same time, if you want to use the DHIS2 data, in a context where we have 84% of deliveries taking place outside the health facility, your data is not going to be complete and you're not going to get the desired result. So based on this finding, CHI worked closely with the Katsina State Primary Healthcare Agency to activate the CBHMIS system. So what is the CBHMIS? CBHMIS is an acronym for Community-Based Health Management Information System. It refers to a system that collects health-related events outside the health facility setting. Some of these indicators include live birth, stillbirth, maternal death, neonatal death, referral to health facility, or even community-based service delivery. How does the CBHMIS system work? Even before Nigeria's independence, we used to have the CBHMIS system where traditional leaders will generate data during the native authorities periods and use those data for decision making. So what we decided to do is to activate that system and use it to capture all these events. We have traditional leaders, we have religious leaders, because they are involved in naming ceremonies and burial ceremonies. All the events taking place in the communities, they already know them. So they capture this information, put them in a register, and then transmit it through the village heads, from the village head to the health facility. From the health facility, then we have the LGA, disease surveillance and notification officers, who will then digitize the collected data using smartphones. It doesn't end there. The disease surveillance and notification officers will come back to the communities and have verbal autopsies, a process where they have an interview to ascertain what the underlying causes of deaths are. And we have trained doctors who will then utilize the collected data to assign the underlying causes of death using ICD-11. We still have a platform bringing all the stakeholders together to discuss the generated data, address data quality issues, or even make decisions to reduce maternal and neonatal mortality. So what are the data sets we're able to record from the CBHMIS platform? From December 2023 to November 2024, across those 5 LGAs, we recorded a total of 1,151 maternal deaths, as well as 77,185 live births, giving a maternal mortality ratio of 1,191. And this is significantly higher than the MMR of 512 per 100,000 live births. And looking at the places where the events occur, deliveries, and even maternal death, majority of them take place outside the health facility setting, as we can see from this chart. For me, one key takeaway from this slide, if you're going to contextualize the mortality, that 1,151 across the 5 LGAs, on average, every day, at least 3 women in those 5 LGAs die because of preventable conditions. So that's a major gap and challenges that we're facing. We need to put our hands on deck to make sure we address this burden, which the Katsina State Primary Healthcare Agency is, of course, leading. Looking at this slide, the CBHMIS database has the ability of identifying the maternal mortality ratio at the level of the local government, at the level of the political wards, and even at the settlement. So making it easier to use that data set to make decisions. For instance, if you can observe the bar chart, Katsina local government had the highest reported maternal death. Gabas 1 had about 71 maternal deaths reported. We have Kudu 3, we have Gabas 2. And that reminds me, during the CBHMIS and IDSR dissemination workshop, we had Her Excellency, the First Lady of Katsina, in participation. And looking at this data, she was able to mobilize resources and identify safe motherhood ambassadors who are going to target these places that have the highest burden of mortality in order to create demand for MNH services. Dr. Shamsuddin Yahya is going to take us through this action in the later part of the presentation. Moving from the geographic distribution to the period where the mortality occurred. Previous slide, please. Thank you. The peak of maternal mortality ratio occurred in July 2024, where we had an MMR of 2,137 per 100,000 live births. We conducted qualitative analysis to understand what the drivers were. And from our assessments, those had to reach localities find it very difficult for them to reach to health facilities, access services, especially during the rainy season. And because of that, it further contributed to the maternal mortality. At the same time, when you take a look at our PCVA database, you realize that malaria contributed to about 6% of the total maternal death reported from the CBHMIS and IDSR platform. And you know, we have peak of malaria during the rainy season. That must have also contributed to that high levels of mortalities, despite the intervention from the state. Next slide. The highest local government with the highest MMR is Katsina, having about 2,000 per 100,000 live births. But the key takeaway for me from this is that across the 5 local governments, the maternal mortality ratio far exceeded the national average of 512. I know some people will be wondering, why do we have Katsina local government having the highest, despite being an urban settlement? You know, in Katsina State, we have security challenges that affected almost 10 local governments or more. Because of those security challenges, people from the compromised places moved to the city center, and some of them are even staying in IDPs, and that contributed to
Hi, Dr. Bukar.
yes, it's not moving yet.
No, you weren't speaking at some point, but please go ahead.
Okay. I'm having some little issues with my internet. Thank you. So what were the causes of death based on the PCV analysis conducted by our physicians? Obstetric hemorrhage accounted for about 41% of all maternal death. When we're talking about obstetric hemorrhage, it looks at antepartum hemorrhage, intrapartum hemorrhage, and postpartum hemorrhage. This was followed by hypertensive disorders of pregnancy, preeclampsia, severe eclampsia, chronic hypertension in pregnancy. But for this slide, the key takeaway for me is the fact that over 95% of maternal death were attributed to the 6 leading maternal conditions: obstetric hemorrhage, hypertensive disorders, and the others outlined here. Next slide. These are the other conditions. We have acute gastritis in pregnancy, diabetes mellitus, and others. Next slide. Another importance of the CBHMIS and IDSR platform is its ability to monitor community mortality, a system of mortality surveillance beyond maternal and newborn health. From this slide, you can see we have the top 20 leading causes of maternal death in those 5 LGAs where we conducted the CBHMIS and IDSR work. To provide more context, during the COVID-19 pandemic, there were a lot of concerns regarding mysterious community mortality, and they attributed that to COVID-19 virus. Fortunately, we have the CBHMIS platform, which help us in identifying, was it due to COVID-19 or was it due to something else? And we're able to identify that just 0.7% of all community deaths in those places were attributable to COVID-19. So looking at these data sets, we can leverage this system to monitor mortality and intervene as appropriate. One key thing I would like to highlight here, you know, when we're talking about non-communicable diseases, we'll be thinking that in rural communities of Katsina, we might not be having a lot of cases of hypertension or diabetes, but it's very obvious, just closely following malaria, we have hypertension and other heart diseases being among the leading causes of death. So that's one key thing for us to take note of. Next slide. There are quite a lot of key takeaways and lessons from the CBHMIS and IDSR work in Katsina. The first one has to do with generating context-specific data, which was essential for evidence-based decision-making across all levels. When you're going to engage any stakeholders, by the time you show the data from the communities, it resonates with them. They find it much easier to make decisions because we have that context-specific data. And another thing, while implementing the project, we work very closely with the traditional and religious leaders. All the project-related activities were led by the village heads, the wards heads. So this ensures sustainability. Another key thing that I would like to highlight has to do with the strategic partnership that existed between the Katsina State Primary Healthcare Agency, CHAI, and Vital Strategy. Katsina State Primary Healthcare Agency was solely responsible for leading the project and community engagement work. CHAI was responsible for providing technical assistance in the design of the project, SOP, data tools, analysis. While Vital Strategy is a leading global organization on verbal autopsy, so we leverage their expertise in building the capacity of our doctors in Kasina, as well as getting softwares for analysis. So everybody bringing their expertise ensured success for the program. And the last one that I would like to take, I know we have time constraints, has to do with dissemination of the results. You can do all these things, but if you don't have platform to share the data, nobody is going to make use of that data for decision making. So it's really important to identify the appropriate platform and share the results. These are some of our action points from the community. So thank you, and I would like to hand over back to the moderator for questions, comments, or even suggestions.
Thank you so much, Dr. Zarami. I mean, what stood out for me especially was how we all used, the community structure as old as the village health systems to actually reactivate all of these things into a modern surveillance pipeline that turned deaths as well as births into a community level data that eventually transitioned into a state database and drives monthly decision making. Thank you so much for that. And just riding on some of the conversations that have been going on is our third but not the least speaker. And this is Dr. Deaya. Please, Dr. Deaya, the floor is yours.
Thank you very much for the opportunity. So my presentation is going to be continuation of what Dr. Bukar has presented. We have the recommendation based on the data that has been generated and what we've been able to achieve with that. So some of the recommendations that we have after the presentation is strengthening emergency transport scheme for mothers and newborn to reduce delays associated with the care. We also have recruit and deploy more skilled birth attendants to provide obstetric services while focusing on capacity building efforts targeting the leading causes of death, as we have seen obstetric hemorrhage and others. Ensure the availability of life-saving MNH drugs and equipment. Conduct qualitative research to understand the community factors contributing to maternal deaths. So these are some of the recommendations. Next slide. Strength. So we also, as part of the recommendation and implication to practice on maternal health, is create awareness and demand for maternal health services to reduce obstetrics delay. We know the 3 delay model. The first delay, if you want to reduce that, you have to really create a lot of awareness and demand for these services. Just like Dr. Bukar has said, our more than 65% of deliveries occur in the health at home. So also even deaths occur mostly at home. And we base most of our decisions based on the data we have in the facility. And part of our recommendation is expand the coverage of health insurance to improve uptake of SRA managed services. This is to, avoid the barriers to utilizing primary healthcare services. And we know the impact of the impact of having out-of-pocket spending leading to catastrophic healthcare expenditure. This a lot, discourage people from going to the facility to deliver. We also recommend that we need to adopt the MPCDSR, including the community component of the MPDSR, in addressing the high levels of maternal mortality missed out in the current system. We also apply innovative MNH intervention, such as the e-motive to reduce deaths due to obstetric hemorrhage, as well as to advocate for the continuous funding and usage of CBHMI's platform. You can see the importance. This is just 5 LGS, and we can see the quantum of information and data that was generated, which I will talk about, the implication and what it has led us to do. And so we give a summary of selected cases of data use for decision making. So just like what Dr. Bukar said, during the dissemination and showing the data to Her Excellency, the First Lady, especially in Katsina LGA, she immediately approved the use of female ambassadors to improve demand for facility-based MNH services. Also, as a highlight, part of the causes of high maternal death is lack of skill birth attendants, which discourage a lot of women from going to the facility. Government, using the data, were able to recruit over 1,000 healthcare workers to provide maternal services. Then, of course, secondly, because of difficult terrain and having, contributing to the second cause of maternal death, procurement of ambulances to promote emergency referral and transportation for maternal services. We've also developed a memo because we don't want this thing to just stop. We've written a memo so that community-based health management information system integrating with the IDSR, Integrated Disease Surveillance and Response, should be adopted in Katsina State. This was done during the State Council on Health, and the memo was further presented during the National Council on Health. And another summary is construction of health facilities to strengthen MNH services. Katsina State is very large. We have over 10 million people with over 361 wards and 34 LGAs. So, like I've said earlier on, immediately during the dissemination of this project, which shows very high maternal mortality at homes, with Katsina LGA having the highest burden, the First Lady swung into action immediately, and she engaged what we call ambassadors, female ambassadors. These are women who go house to house, especially focusing on those the three highest wards that are contributing to the maternal mortality. So you can see this is our First Lady during the dissemination, where she directed that, where she recruited these female ambassadors that are going to work to support MNH intervention in the state. These are some of the pictures of the female ambassadors with their, you can see their kit. This is during their training, and they have data tools that they go house to house identifying pregnant women so that they refer them for ANC, and when it is time for delivery, they also go to the facility for delivery, as well as children that are identified to go for routine immunization services. Next slide. So during the time these female ambassadors were engaged, they were able to make a total referral of 10,854 women. That's just in one LGA, and the referral is 3,536 for ANC. Almost 4,000 women were referred for delivery, and 3,700 children for routine immunization. These are numbers that ordinarily will have remained back at home, and quite a number of them will have been part of the numbers of maternal and infant death, but they were referred to facilities, and this has improved our skill birth attendance at delivery. Next slide. So to address the issue of delay when you reach the facility, the third delay, we have made case based on this huge number, and we got approval to recruit 1,030 frontline healthcare workers for MNH services. Most of these that were recruited, about 75 to 80% of these were females. You can see from the picture, this is the cross-section of them during the orientation of those frontline healthcare workers. And the other picture is the governor presenting the letter of employment letter to one of the successful candidates. And this is just one of the commitment that was done based on the data presented. And these frontline healthcare workers have been deployed to the high burden LGAs and wards identified through the CBHMIS project. And we've known that the second delay, when we identify problem, moving them or transporting them to the facility constitutes the second delay of maternal mortality. So what has the state done? The state has advocated, we've advocated for the state to procure and distribute over 260 motorbike ambulance in rural areas due to high maternal mortality ratio, just the case that was presented by Dr. Bukar. Apart from these tricycle, call them tricycle ambulances, you can see them. They are simple and adaptable to the rural areas. Additional ambulances were procured to transport women with complication from PHCs to other services. In addition to that, please, can you go back to the last slide? The government has we have established the State Emergency Medical Services and Ambulance Unit. This is an agency solely focusing on the issues of maternal, to address all issues as it relates to emergencies. His Excellency, the Governor, last week has signed the bill to establish these SEMSAs into law, and this will make sure that issues relating to emergency maternal services are addressed. Also, we have the rural component of these emergency services known as RESMAT. We are collaborating with the National Union of Road Transport Workers, and we are focusing on the 15 MAMI LGs so that we use the data and address where we have issues. You can see these are the pictures of the tricycle ambulances that were procured, and they are, they are adaptable to the local terrain, and you can see the inside of it. We have some emergency kits, and this will go a long way in making sure that we adequately shorten the second delay in pregnancy. Next slide. Apart from the tricycle ambulance, we have these advanced life support ambulances that are procured, and they are going to be distributed to major LGAs, and they will serve also as a bridge to ensure that we address the issue of maternal mortality. One of the things that we identified during the project is weak PHC system, and based on that, we can go to the next slide. Upgrade and revitalization of primary healthcare facilities. Can we go to the next slide? The government has taken an ambitious step in making sure that we revitalize primary healthcare facilities. And so far, we have over 260 facilities that have been fully revitalized in terms of infrastructure, equipment, human resource, like I've mentioned, staff quarters, fencing, and all the other water and supply and hygiene component. So these facilities are fully revitalized. They have the full complement of healthcare workers. In every ward, our aim is to have one functional PHC per ward in every ward, so that it's going to improve access to quality primary healthcare services, so that it will shorten the delay in every political ward. You will have a facility with this full complement of services. So these are some of the things that we've been able to do to ensure that we address these issues and resolve the issue of a high maternal and infant and neonatal mortality across all the facilities. So by the end of this year, we have gotten approval to make sure that the numbers become 361, so that we have in every political ward these ambulances, including the tricycle. I mean, we have these facilities. We have adopted the CBHMIS and IDSR. We've presented this memo at the State Council on first maiden State Council on Health picture up is when we made the presentation, and the second picture is during the National Council on Health. We also presented as an information memo to the at the Meduguri, and you can see the approval given by the Katsina State government for us to adopt community-based health management information system as part of the system to gather information that will use for improving healthcare access in Katsina State. Next. So we have, as you know, there are many LGS, about 100 LGS that have been categorized as contributing to the highest number of maternal deaths in Nigeria. And Katsina State have 15 of those LGS. But based on this evidence, we have notified NPCD that these two LGAs, Katsina and Mani LGAs, have been excluded from the 15 LGAs under MAMI. But because of evidence, we are representing these LGAs so that they will be included, even without waiting for the support from NPCD and others. We are prioritizing these LGAs. We believe that if we can address these LGAs, and not just the 15 MAMI LGAs, all the other LGAs, they should have basic minimum package of services, having revitalized facilities, human resource for health, and all other complements of services. It will go along in rather than just focusing only on the 15 MAMI LGAs. So evidence has shown that apart from those 15, these are the two LGAs red. You can see the national average is around 500 and some and 12, while most of them, like Katsina LGA, is over 2,000, and that is why we are prioritizing them and making sure that we do whatever whatever is necessary to address these issues of high maternal mortality. And we have our ongoing discussion to reconsider them. Even without that, like I've said, we are going to make sure that we prioritize all the 34 LGAs, because the tendency is to focus on only the 15 LGAs, leaving the others. While you have intervened, you realize that, okay, others have gone down, and the cycle continues. So that is why we are making case for these two LGAs and all the other LGAs. Like, that we battle with a lot of insecurity in the state. Next. So So what are our priorities and next steps? As you can see from our presentation, the government has done a lot, and it has prioritized primary healthcare, revitalizing over 260 PHCs with the full complement of services, infrastructure, equipment. So we also want to advocate to His Excellency to further dedicate more funds for maternal and newborn health system. The government is doing that, but we still want to advocate for more funding. We want to expand the community data collection and surveillance system to cover all the LGAs. Right now, we have only focused on only 5 LGAs out of the 34 LGAs. And we are also calling on and soliciting for donor support so that we'll be able to have funding to escalate and cover all the 34 LGAs. A lot is happening in the community outside the health facilities. If you base all your interventions based on people coming to the facility, you are missing a lot and you continue to miss a lot. But if we can invest in a system outside the health facility, we'll be able to get a lot of insight. We'll be able to generate a lot of data that will inform our decision to do a lot, just like we have highlighted. We are also working hand in hand with Katsina State Contributory Health Management Agency to enhance and expand health insurance coverage, especially for pregnant women living in rural areas. This will go a long way ensure that we improve access to financial access and reduce out-of-pocket expenditure and catastrophic healthcare expenditure, especially in people that are living within the rural areas. These are some of the our priority next steps. Next. So in conclusion, the value of maternal and newborn health data lies in, can we have it? The value of maternal and newborn health data lies not only in its collection, but in its context-specific generation, timely analysis, dissemination, and use to drive actions that save lives. So you can see it clearly being shown that beyond collecting the data, it is important to put this data into action. And whatever you need to do, you should be guided by that data, as demonstrated in this case study in Katsina State. So we want to acknowledge this Bloomberg Data for Health, Clinton Health Access Initiative, Vital Strategies, and even ACE for giving us this platform to disseminate this our findings. Thank you very much.
Thank you so much, Dr. Yahya. I mean, you've just said it all. Using data has enabled all of these efforts at the grassroots. Thank you so much to our speakers for this rich and grounded perspective. I mean, before we are open to questions, please, our participants, use the chat box to leave your questions in. And if you intend to, ask live questions, please show a raise of hand using the features, and we will call on you and unmute you just for your questions only. Across all of these conversation, I mean, all that has been emerging from this is that the health workers and our community informants are all bargaining on the data that they collect to be used for adequate decision making. Thank you so much. And we have actually seen that maternal and child health data already exist, and what we should be building is a system that acts on this knowledge quickly and on scale. Thank you so much for this insightful reflection. So just moving on to our cross Q&A for now. So we have some questions already from our participants. Very interesting questions at that. I'm really excited, for this very part. We have one from Dr. Manir Ahmed, and he said, "Thank you so much for your presentation. It's indeed a good insight. Very important topic." He said, "Please, could you highlight for me what are the most effective strategies for ensuring that maternal and newborn health data collected at the facility level actually influence decision and resource allocation at the state and national levels?" So I'll take that again. Please, could you highlight for him what are the most effective strategies that has worked for ensuring that maternal and newborn health data collected at the facility level actually influence decisions and resource allocation at the state and national level, as the financing is the major gap for MNCH program? He also has two extra questions, so I'm just going to read it all, then have you answer them. So his second question is around community level data, such as the MPCDSR. He said, how can community generated data, especially from underserved population, be better integrated into routine health information systems to improve maternal and newborn better strategies and outcome regarding the reducing the burden and death of maternal and newborn? And then our third question is, could you share an example where the use of this data changed the cost of a maternal and newborn health program, and what accountable mechanism helped in doing that? I think number one and number three have some quite similarities, but if you could answer them, that would be very good. I think this question is directed to Dr. Booker.
Thank you so much, Dr. Manir and Chidera, for reading out these questions. So looking at the last question that had to do with specific examples where data was used to reduce mortality, I think Dr. Shamsuddin Yahya has touched on that. And I want to give another example. CHAI implemented a maternal and newborn health program in Katsina State across 10 LGS, where we had community-based intervention as well as facility-based intervention. Still, using the CBHMIS database, we're able to demonstrate a significant reduction in maternal mortality ratio by about 37%, neonatal mortality rate by 43%, and stillbirth rate by about 15%. This has already been published in a peer review journal. If you need more information, I'm going to share that with you when we're done with this session. Then talking about how do we ensure that we have a platform of integrating community-related activities with health facility structures. We already have the MPCDSR policy, which was released by the Federal Ministry of Health somewhere around 2022. And it details all the process. We have committees in the community, we have committees in the facility. How do these committees interact with the LGA level MPCDSR committee? How do they fit information to the state level committee and the national? How do we ensure all these responses fit into the annual operation plan, the state budgets? They are all outlined in the national policy and guideline for MPCDSR. So please, I will refer you to that document also for you to have a better understanding. Thank you and over.
All right, thank you so much, Dr. Oboka. So this next question, hi, Dr. Manu, does that answer your question? All right, so just moving on to the next questions. We have some hands raised. I'll just take one more question from the chat box before we move to the live participants. All right, thank you, Dr. Manir. So we have one who, the question is directed to Mr. Nanman. He said, please, what were the challenges you encountered in ensuring the accuracy and completeness of level data, and how were they addressed? I'm going to take that again. Please, what were the challenges you encountered in ensuring the accuracy and completeness of facility level data, and how were they addressed? This is directed to Mr. Nanma.
Yeah, thanks, Chira, for the question. I think it's spot on. I think the challenges with data, especially at facility level, are probably compounded by a few factors. In some cases, the required tools are not available. In some cases, health workers are overburdened to actually documenting a lot of registers for different services that they provide. And in some cases, sometimes it's just even a lack of familiarity with the tool and knowing what to document and where. And so I would say as we implemented, all of these were apparent, but then it was then working with the health workers to address specifically what the challenges were. As a project, just because we had boots on the ground, we're able to deploy M&E staff that could work with the health workers directly to address the challenges. And anecdotally, these M&E officers have reported improvements over time in terms of just how data is reported or inputted into registers. Of course, things like the tools not being available, you can work with stakeholders to make it available. You can use your M&E staff to provide training and capacity building to ensure that what's needed to be documented is documented appropriately. And over time, with that kind of routine support and hand-holding, you can then have some improvements in terms of the quality of what's documented. We've also tried to, in instances, triangulate what's in the tools in facility by what's reported here on DHIS2 and just try to ensure that there's accuracy and there's improvement in that as well. Of course, for things like the burden on the health workers, you might not be able to influence those directly. But when you think of some of the complementary things that are happening, like Dr. Shamsuddin said, around more recruitments, that of course has to ease some of the burden, and that could also help in terms of what's documented as well. So I think that's how we've sort of addressed that as a project. Over.
All right, thank you so much, Mr. Nerman. I hope that answers your question, person who asked this very question. We have one interesting question in the chat box, and I really want to ask that question before we move on to the live participants. This is directed to Dr. Yahaya, who mentioned that you mentioned how the First Lady became actively engaged after the findings were presented. And it made me wonder whether the impact is driven not only by the quality of the data itself, but also on how that data is framed and communicated. In your experience as an ES, how important is the modality of the presentation, the choice of the messenger, and even the framing of findings in influencing whether decision makers actually act on the evidence? I would take that again. So you mentioned, the comment said, you mentioned how the First Lady became actively engaged after the findings were presented. It made me wonder whether impact is driven not only on the quality of the data itself, but also on how the data is framed and communicated. In your experience as the ES, how important is the modality of presentation, the choice of the messenger, and the framing of findings in influencing whether decision makers actually act on evidence?
Thank you very much. I think it's very important how you frame and how you present your data. When we made the presentation, I mean, she's a woman, she's a mother, and this is not just what I realized is that it's good to have a very good collaboration. And she was appointed like a patroness to us. Whatever programs we do, we have very good, synergy. We work together with her. She has a similar NGO. When the data was presented, everything was presented to her, and the tone it was presented and the call for action, she had no option than to, do something urgent, because we told her these are live, these are not just numbers, these are real people, and this is, this is happening right within the state capital. So that has really touched her and made her to make commitment. Not just her at that meeting, we have other stakeholders, including the traditional, religiously, and partners. Many people were touched and they had to make some commitment. And not just what he has done, you can see the quantum of things we've been able to achieve in terms of 2 years ago, before the coming of this administration, we don't have this kind of achievement in terms of revitalization of primary healthcare. Most of our facilities, the focus of the government is at the secondary facilities. But with this data and evidence, when we had to do some advocacy brief, we had to reach out to them, telling them how important, and as much as not just the First Lady, but even the governor, for him to commit such amount of funds and to do these things. I believe a combination of so many factors is very important in making sure that you get their political will and commitment. So I think this has really helped us in achieving most of the things that we have done. Sometimes, for like example, recruitment is very difficult for most government to do at that scale. Knowing that if you recruit 1,000 frontline healthcare workers is more than recruiting 3,000 or 4,000 teachers because of the salary disparity in salaries. So it's very difficult. But when you show them the actual numbers, We and the people, quoting these are the people that died in so places. It evokes some kind of emotional, response so that they'll be able to do that. I think we have done it over and over, even to the governor. Once we have any opportunity to have one-on-one with him, tell him these are the people, these are the actual settlements that these things are happening. We get almost all our requests, approved. So I think there is no one magic, but you just do your work, make it very appealing. Don't present so many slides. One or two slides will do the magic. Present it very clear, and so that if you say you want to do so many literature, just one or two slides, bring out your key messages and in clear terms. They will want to ask more questions, and you tell, okay, what do we do? You tell them, okay, you can do 1, 2, 3. At my own level, what can I do? At the level as a governor, what do you think we can do? So these are some of the things that we do, and we have been seeing results. Just like the establishment of this SEMSA, State Emergency, medical ambulances system. We just got the final approval last week. This is something that we've not we had to use the same evidence to show that if we can do that, it will go a long way in reducing these things. And they are inquisitive; they will ask questions, and we cite examples. Okay, Yobe State has done this, and this is what they stand to gain out of it. Apart from addressing the mortalities, even the state need, some of them there are some DLIs linked to establishing such things. So you bring all your arguments together, and you see positive result.
Thank you so much, Dr. Yahaya. Just we had a live participant who had her hands raised. Ebere, can you still ask your question? I'm going to love to hear from you. Okay. All right. All right, we'll just take Promise then. Promise, please, over to you with your question.
Okay, I had already. Hello?
Hello, can you hear
Please
me?
go ahead.
Okay.
Sorry,
Okay.
Promise, hold on. Ebere, please go ahead.
Okay, good afternoon. It's a privilege to be here and hearing all the dialogue about medical sector and all that. But I had already posted my question on the chat box, but can I still ask it here?
Of course, please go ahead.
Okay, so like I said, I'm glad to be here. I just joined because I'm fascinated about the medical, about statistics in the medical sector, data, and everything in between. So I want to give a shout out to INS for putting this together. So my question goes to Dr. Bukar. So I listened fervently because this is a project I've worked on before, because I was interning in one of the NGOs that was working with Chai in 2019. So I was asking whether there has been a level of improvement, because I happened to be the person that was reporting for Kano, Katsina, and Kaduna. So we're reporting all through putting together the meetings. I couldn't speak Hausa, obviously, so I was interacting with those on the field and reporting their responses. So would you say that there has been a, how do I put it now? Would you say that there has been an improvement from 2019 till now in the health sector, like our data set being implemented and the right decisions being taken? So that's the first question. And then the second question is that I'm also fascinated about your data visualization and everything you use. So I also want to find out that whether it's the normal software that we use for data visualization that you use, or you use other data sets, you use other softwares for data visualization and data analysis. Thank you for your time.
Thank you so much, Ebere, for that. Hi, Dr. Buka, over to you.
Thanks, Chidera, and thanks, Ebere, for those questions. The answer is very simple. Do we record any improvements in the past years? We have succeeded in getting a lot of improvement over the years, but there are a lot of changes in government policy. A lot of people drifted to poverty. The living standard has reduced. There are lots of intersectionality between the health sector and other places. So to answer, the answer is no. Obi or more results, let's say from the NDHS, to see whether there's any significant improvement from what was reported in the last 10 years to what we had recently. For the software used for this analysis, well, there are a lot of modifications. We use Power BIs, we had preform templates and many other things, including generating templates from nowhere. So you can follow up with Nation if you need further information. Thanks and over.
Thank you.
Thank you. Thank you so much, Dr. Buka. I think we have one more hand raised from Charles. Charles, do you have your questions ready? Please, over to you.
Okay. Good evening. Thank you all. It's a privilege being here, given that I just got the notification from someone on LinkedIn, and then I decided to join in. Mine is not entirely a question, although it's a question in a way, because I recently carried out a study to check the, just a background. I'm a National Health Fellow, Cohort 1, and our job basically was to assess primary healthcare centers across our respective local governments. Mine is in Enugu State. During my field work, I was exposed to the gaps in primary healthcare, and which explains some of our high maternal mortality rates. So I decided to, because out of the program, I decided to do a personal research on it so that I will get an unbiased result to be able to inform me. I'm a medical doctor, so I have some of the knowledge about these WHO-based assessment tools. So I used one to assess the readiness, that is facility readiness and referral preparations. And I found a very huge, even though it's in Anambra State, where we have at least a well-developed healthcare system, somehow, relatively to other states. So still, I found about 70-something% gap. Most of the facilities are not ready. They don't even have referral protocols. Some do not have referral records. Some do not have, just let me not waste our time. But now, this is data. The theme of this webinar is data to action, stuff like that. So now this is data. I have it. How do you take action when people would not listen? When people would not give you the audience to present this to them? I reached out to several people in my network. Some responded. At the swap level, someone responded, referred me to, there's something called MAMI. I don't know how many of you know about it. So each state has a MAMI coordinator. I have one I have been referred to the one in Anambra. There's this disconnect in the communication gap, and it's frustrating the effort I'm trying to make to see how we can integrate this into a project that can help, because some of these people, they don't even know. Some of the data presented here today is that most of the beds we have are even outside the facilities. There is no record. Some of these records we are having are just estimated. Most times there are no records of most of the deaths. I saw somewhere 3 women die daily. There are more, because from what I saw in the field and from what I did by I'm not saying someone gave me data. This one is what I did by myself. Let me just, but my main question is, how do you get audience where none is being granted? Because I need audience and I need to show this to people. Let them see it. Let them see that there are more than one ways we can tackle maternal mortality rates. And one of them, a very important one, is facility readiness and referral protocol. Thank you.
Thank you so much, Charles, for that question. Is this question directed to Dr. Bukar or this is directed to Dr. Yaya? I mean, knowing that Yaya, who is an ES, have experience in directing some of the audiences or the data they've gotten to the right audience. Who would you like to answer this question?
Dr. Yahya is obviously in the right place because he is an executive secretary of Primary Healthcare Development Agency. And if the other person has the answer, I think there's a CHI person here too. I know when we were creating a roadmap, MAMI roadmap, we had, it was a co-creation between so many stakeholders, including the CHI and all that. So anyone who has the answer should please.
All right. Thank you so much, Charles. Please, Dr. Bukara, please answer this question.
Maybe I will talk.
Okay. Yes, sir. Go ahead first. Then if there is
Yeah, I
anything to
think
add.
since you said you are a health fellow, and we have, like in Kasana, we work with health fellows, and I think you are posted to a particular LGA. You are supposed to work with the director PHC at that LGA. You have an idea, you want to share it. I believe you can approach them, or you can meet the executive secretary of the primary healthcare. Maybe I can, talk to her so that you'll be able to present this thing, and from there you can move on. I believe whatever you have that is very interesting, health fellows are part of the health system now. So you should be able to, break that barrier and get to them so that they'll be able to, as long as whatever you have is very interesting and you present it in a way that, it will capture you have to target your audience. Like I've said, that if you don't come with something that is very simple, break it down. And if you go through that process, you should be able to reach and the relevant people that are supposed to support you, and so that you actualize whatever you want to do. I think this is my advice on that. Things are not always easy. There are a lot of our policy makers, a lot of competing demands. They have to think about so many other things. There are issues of insecurity, education, water, so many myriad of problems. So sometimes it's not easy. Don't give up. I think you can go through that procedure. I think it will help you in. You can also approach some of development partners in your state, the WHO, UNICEF, and others. Even the facilitators at the LGA level, that the people you work with, present it to them, the LGA team. You'll be surprised from there. It can go up. Start at the LGA level. For example, we had somebody that came up with an innovation in Katsina State. He started at a very far remote LGA, and we saw it. He used the opportunity during a review meeting that they were invited. He shared with us, and from there we adopted it for the whole state. He's somebody that it was an idea, but he used that opportunity during the meeting. He presented, and we got interested. And luckily enough, that time we had funding, and we use it in all the zero dose LGS, as well as other security compromised LGS. So thank you, and over.
Thank you so much, Dr. Hayaya. Charles, I hope that answers your question. We still have some hands raised. Please, we will be engaging with you in our next segment. But moving on, let's just take a pause on the questions and answers. But this conversation is far from over. We have an even more interactive exercise coming up where we would read out instructions as well as a scenario. This is where we are putting you in charge of making the decision. We want to know how you would think through some of the impact you intend to make. And this data is an example of what a real LGA health team might have on the field. So this is the reality that they are facing. And at this moment, it is yours. So I implore all of you to please engage. So here is the scenario. For instruction, you would review the scenario and give you the data set, and then you would analyze the available data and identify the most critical bottleneck. Using that bottleneck, you would select one intervention that you believe will be the greatest impact on reducing newborn deaths. So here is the scenario. A local government area health team has recorded a 35% increase in newborn deaths over the last 3 months across 5 primary healthcare facilities. The LGA has limited resources and can only implement one major intervention immediately. The data is showing and has revealed that 1, skilled birth attendants trained in managing deliveries are present for 80% of the deliveries, but lack essential tools and supplies to provide life-saving care. 2, we have essential newborn medicine and resuscitation supplies that are out of stock in 4 out of 5 facilities. About 85% of newborn deaths were linked to treatable conditions like our neonatal sepsis as well as birth asphyxia. Only 40% of women deliver in health facilities. Yet, mortality among facility-born newborns have increased fourfold. Average referral time is 45 minutes, indicating the referral and the transport system is functioning adequately. And lastly, the data is showing that reporting completeness is 95%, enabling the health team to quickly detect the rise in newborn deaths. Please, I would like to point to you the poll on your screen. Please take a moment to fill it, and we genuinely want to hear your thoughts as well as a reflection of all of the things you've heard so far. Your responses will shape the rest of our conversation today. So just again, I'm going to read out the data points we've identified. Skilled birth attendants trained in managing deliveries are present for 80% of deliveries, but lack essential tools and supplies to provide life-saving care. Essential newborn medicine and resuscitation supplies are out of stock in 4 out of 5. Only 40% of women deliver in newborn facilities, yet the mortality among facility-born newborns has increased fourfold. Average referral time is 45 minutes, indicating the referral and the transport system is functioning adequately. And then we have reporting completeness, 95%, enabling the health team to quickly detect the rise in newborn deaths. Please vote using the poll on your screen. We have option A, train more health workers. We have option B, involve emergency referral system or improve emergency referral systems. We have option C, ensure the immediate availability of essential newborn medicine and supplies. And then we have option D, strengthen data reporting and tracking system. Please cast your vote now. 2 minutes. I can see the vote coming in. Please click on your preferred results or your preferred answer. Well, the votes are in, and the results, I mean, they're quite interesting. Before we show the full result, I would like to hear from about two people. I mean, before all of our speakers weigh in, kindly show indications by raise of hand if you're interested, telling us why you chose that very answer and what drew you to it exactly. Okay, I guess you all want to use the chat box. Hi, Usman. You have your hands raised. Do you have anything to add to why you chose this very result or very answer?
Okay, on mute. Okay. Hi, Chidera. Good evening, everyone, and great listening to everyone so far. For me, I think making provision for to ensure essential availability of essential newborn supply and medicine is very important, considering that it's an urgency need, right, where the LGA need to make prompt decision. And it also means that with the little resources that the LGA has, they can cater for their immediate need within their means. Meanwhile, it will be easier that way, where before they do referral, can they even take care of the people that are giving birth within their community so that they can mitigate the issue of mortality within the LGA. So that's the reason why I selected option C in ensuring immediate availability of essential newborn medicine and supply. Thank you very much, and over from my end.
Thank you so much, Uthman. I think we have a Chukwebuka's hand raised. Hi, Chukwebuka. Oh, Chukwemeka, sorry. Do you want to tell us why you chose your answer before we get to our speakers?
I think I'm going for the supply of essential newborn. I choose it because for me it is the central point of all other concerns, because we have the home delivery, who's also lacking in skill, but also they are lacking supplies. And we have also mortality in increasing in the facility as well, which contributed to 43%. And this can be treated if the essential health supplies, medicines, are available. As an LGA and someone that has been experiencing this kind of programmatic, we can, since we have limited resource, we can provide these supplies across available. And then for training and capacity building, it's something that we can actually do without even leveraging on the expertise of the team we have in the LGA or partners we are working, which may not really need the LGA to use their resources. So for me as an LGA decision maker, I will make sure that the supplies are available, while I can leverage other available systems to train the health workers, both in the facility and the TBS in the community. Thank you.
Thank you so much, Chukwemeka. Yes, we'll just have one more space for Queen. Hi, Queen, please go ahead and just tell us why you chose your answer.
Okay, good evening, everyone. I chose train more health workers because in 2 weeks, I lost 2 friends due to childbirth, and not because they didn't get to the hospital on time, but because those people that were available were not really skilled, or I don't know how to put it, but rushing them to 4 different hospitals and no one could save them and they all died. So it's more like having everything but not good hands that can actually make use of what you have. So training them, for me, training them, it's just what we need. Having them trained for what is available, not have equipment and other things available, and having people that are not skilled to use them. Thank you.
Thank you so much, Queen, for that perspective. I mean, it's equally so important. We would have one more person, Bukola. Please go ahead and tell us why you chose your answer.
Good afternoon, everyone. Well, in this scenario, it's not about training health workers, because the health workers are actually skilled in attending to the neonates when born. But there is something that is so essential in attending to this neonate, because when neonates are born, your method of resuscitation matters, especially the first 30 seconds. It really matters. But when there is nothing to carry out this resuscitation, there is no tool, there is no supply. And you can see in the second he said, many of the things that they want to use, they're stuck out in 4 of the 5 facilities. So even if you train health workers and what they are going to use is stuck out, it's not available, the mortality will just be in status quo, will even increase. But making use of what you have skilled health workers, then make the appropriate tools available for them. Let them have the tools. If they have the tools and you are now still recording infant mortality or neonatal mortality, then you know that there is something more germane that you have to look at. But for this scenario, the tools are not available. Let the tools be available. Let the facility be accessible. Let the health workers have what to use. Then you will see there will be a significant improvement in the neonatal mortality that we are seeing. Thank you very much.
Thank you so much, Bukola, for that response. I mean, it captures all of the things we've just talked about. So I think we'll just give one more opportunity to one of our participants. Amos, please. Hi, Amos. Do you want to tell us why you chose your answer?
Yes, please. Good evening.
Good evening. Please go ahead.
Yeah, I chose strengthening of to strengthen the tracking reporting. Now, this is because I believe some of these challenges are being underreported, and it's making the general public believes everything is fine. There are cases where we get neonatal death of probably, let's say, 5, but the one being reported is 1. So the general perception would be like everything is fine, but in the real sense, there are high rates of neonatal mortality. So when they strengthen the data reporting, I believe for me, it will kind of reduce the mortality rate of neonatal deaths. That's why I chose to strengthen data reporting. Thank you.
Thank you so much, Amos, for that. Now we'll just move on to our speakers who will be giving us better insights on the kind of decision and what decision is paramount for this. Over to you, Dr. Zaram.
Thank you very much, Chidera, and the audience. Listening to all these discussions, it makes my work much easier because they have already answered the question. But one key thing that we need to remember is that you have only one option. You can't do everything. All of them are important. You have limited resources and you have to focus on only one option. For Queen, I really understand your pain and the challenges, going to health facility, healthcare workers don't have that capacity to provide the needed services. It's really painful. But we're looking at what the data says here. We already have SBA rate of 80%. So it means we have adequate healthcare workers. But by the time we train healthcare workers without having available commodities for them to do that work, it's as good as not having them in the first place. When you supply them with those essential commodities, they already receive some sort of pre-service training. So they can use that pre-service knowledge for them to provide the needed services. But if you don't have ambu bag, you don't have IV fluid, you don't have antibiotics, how will you provide the needed care? You understand? So in this context, I don't think training is necessary. For referral, yeah, it's quite important. They have a good referral time, meaning the place is not that far. It will be easier for the patients to reach the nearest health facility within 45 minutes. But when you're looking at newborn care, the leading cause of death is associated with bad asphyxia, right? And for bad asphyxia, like someone else mentioned, you need to act immediately. By the time you take 45 minutes before acting, that patient must have been dead and it will be too late. For M&E system, it's really strong because they have 95% completion rate, and they were able to detect that increase and decrease in the last 3 months. So I go with the audience too. I will choose essential medicine and supplies. But I don't know what Dr. Yaya's thought is regarding this. Over to you, Chidera.
Thank you so much, Dr. Bukar. Over to you, Dr. Yaya.
Thank you very much, Chidera and Dr. Bukar. I think we should remember the golden hour doesn't forgive stock out. Looking at the case scenario, all these are, the factors are important, but just like Dr. Bukar has highlighted, newborn problems, the first thing first, bad asphyxia, issue of sepsis, hypothermia, of prematurity. These are the commonest causes of neonatal death, early neonatal death, and the fact that these skilled birth attendants have been trained, and for you to make impact based on little resources, I think it's very evident that we should prioritize essential newborn medicines and supplies. Once you can do them, it will go a long way for the survival of that child. That's why we have ABGA school. Immediately a child is delivered, you have ABGA school, at 1 minute, at 10 minutes. So things you do or undo within first 10 minutes will determine the outcome of that baby for the rest of his life. Issues of vitamin K, most of these skilled birth attendants, they have been trained pre-service before joining, and what you need is the low-hanging fruit is to provide these essential newborn medicines and supplies. Others are, for long term, but this one, based on the case scenario, I will also go with the audience. Thank you, and over.
Thank you so much, Dr. Bukar and Dr. Yaya. I mean, this everything that has just been said today, it's just some of the things that I've thought about. Just before we go on to our next segment, we're almost done. Thank you so much for your interactive sessions, as well as using the use of chatbots. I guess I've learned 3 things that are cross board from this conversation: that data eliminates all of the guesswork you can think of. Without data, we all default back to training. But the data is telling a completely different story. We also have our strategic prioritization, where we are doing the little things that would fix everything. And we also have strong reporting systems as well. I mean, thank you so much, because all of these things are actually moving into operational action and not just the end itself. So moving on, I will now turn to our managing director, who is Afiz Olajiri, to give us or share with us his reflection, as well as all of the things that we've said today. And thank you so much, everyone. Over to you, Afiz.
Yeah, thanks, Chidera. It's been quite amazing listening to the conversation. Can you confirm you can hear me, Chidera?
Yes, we can, sir.
Yeah, so thank you so much, Chidera. Thanks, everyone. This it's been one of the most exciting sessions I've listened to. Thank you to Dr. Shamsuddin Yaya, Dr. Bukar and Nama, and yeah, for everyone who has participated till this very moment. It's quite amazing to see over 80 participants listening actively and engaging in this webinar. So thank you so much, everyone. I think one of the key things that stood out for me in this conversation is the need for us to see data. I love the part where one of the speakers mentioned that there is more inclusiveness in decision-making after some data was presented to the First Lady. And that underlines the way we like to see data here at ACE, where we understand that data goes beyond collection. Of course, we need to, as much as people focus on collecting the data, analyzing it, I think there needs to be some intentionality in visualizing it in a way that it is clear enough for dissemination. Because as much as the data could be staying over the shelf or anywhere, if the visualization and how we represent the data is not good enough, anyone we are engaging with that data is likely not going to be able to take anything out of it and make decisions. So, which is one of what our Insight Hub tried to do, that how can we simplify what the data is saying for different target audience. So if I'm talking to a market woman about maternal and newborn health, what I should be showing them is different from what I'll be showing a professor or a researcher or an academia. Because the interests differ, the understanding differ, and what will stimulate their interest will always vary. So that's how we like to see data. Another thing I think I've enjoyed in the conversation is the need for us to contextualize data. The outcome of data is same. It's only one truth, but we need to always contextualize it to what we need it for. And that is going to determine if you get people to follow what you are saying, or people will drop off from the reality. So at ACE, this webinar contributes to part of what we stand for, because our experience will continue to show that the real value of data lies in how we use it to drive decision-making and coordination. So nobody, I'm sure we all walk away knowing that collecting data will not be enough. We'll stop applauding for data that is analyzed and kept over the shelf, and we now look more into seeing data actually informing decision, using it to engage people. And when we say we are using data to engage people, people like to see it as we collect some numbers, we analyze, we visualize it. That's not just data. If you find yourself in a community where we have more than 10 children around your house complaining of a sign that look like measles, your ability to quickly go to the nearest health worker and telling them that over the last 2 months or over the last 2 weeks, I've been noticing a lot of the children in my community having some signs like rash on their body, eye fever, and all of that, is you disseminating data and making data to take decisions. So that's part of what this webinar is supposed to unpack, knowing that data, harmonization, analysis, and all of the big words that we're used to hearing is not just how you could disseminate data. As long as you are harmonizing some information, whether qualitative or quantitative, to inform decision, advocate, or stimulate a response, you are disseminating data and you are using all of those. And that's underlined in how we do most of the work we do. There is our support with the strategy support team, embedded within the MDAs and funded, of course, through some of our donors like Gates Foundation and other donors. And what the strategy support team try to do is to ensure that we have some data-enabled alignment, to ensure that what every partner is doing has some complementarity, to look at how what A is doing, how it's going to affect what B is doing. How if I'm going into a state where child is already doing CBHMIS work, I'm not reinventing the wheel, and I'm just plugging into what exists to make sure that we maximize resources. I love when one of the speakers spoke about resources. In a world where we are grappling with fiscal space, things are very tight to, we are struggling with limited fiscal space. We don't have enough money for all of the implementation, and we still continue to do what somebody else has done. You go to one state and you're realizing that 14 people have been here to collect similar data, and every one of them had to recruit some people to collect data to analyze it. So there is need for us, and that's what the strategy support team tried to do, to look for a unified framework that use program data to align partners, telling this partner that, you know what, you are here, X person is already doing this, so we just need you to do this for us to reduce the fragmentation and improve the collective performance. And seeing every work we do as we are not working for ourselves or for our self-pride, but the big goal is the people we serve, those vulnerable community, those women and children that want to ensure that they live to thrive, they carry their pregnancy to term, they deliver safe and healthy. The children that want to ensure that they survive beyond the age of 5 and they survive to full potential. And also, we try to ensure that there's data improved coordination and efficiency by mapping all of the activities and outcomes and use that to identify where there are overlap, how we need to reduce duplication. And some of our workers inform donors saying, you know what, we are pulling this person out of here to redirect their support to here because we already have enough saturation here to get us the kind of coverage we want. So we did some work around digital literacy for women project as well with, I think, an organization called Aruna Ocean Consulting, where data actually showed us that digital literacy for women can help us uncover access gap among women of reproductive age and help us clearly identify underserved population. Some of the data work we've done, I think there's the work we did in Zamfara one time like that, and we realized that the community that kept their immunization card for their children most were the most affected by insurgency and flooding. And when we probe further to know why we are struggling with all of this, and that still makes you see a need for you to keep your immunization card and all of your health card, we realize it's just one magic. They need this health card to access social relief anytime there is social relief in their community. And that has helped us advise these development partners to shape their program. That rather than continuously forcing and spending a lot of money to advocate for people to come for immunization, if we reduce the incentive for me vaccinating my child, people will naturally bring their child out for vaccination. I'm sure the reason why most people on this call went for NIN or all of these DVN and co is because they need it to assess something. If none of these is having any value, I'm sure most of us will probably not make all of the sacrifice we made to get it. So we understand evidence should guide targeted intervention. And across the two projects I mentioned, one recurring lesson that we've learned is that data should not just be collected and kept on the shelf. It must always guide strategic decision-making, how programs are planned, how interventions are tailored, how responses are timely, and now we are using them to unlock the bottleneck. And looking forward as an organization who continuously engage with every other partners in the space to ensure that we have one focus, one mission, one agenda. And that is that we want to crash maternal mortality. We want to ensure that every child lives to thrive and they live beyond what the societal norms are set for them as a barrier, but rather they live to their full potential. So we are looking to strengthen integrated data system that connects community and facility level. We are doing a lot of work around strengthening referral linkages to ensure that if a woman must even deliver at home, there is an automated system that can get them to the facility. Because we also understand from some of the data work we've done that if you need to mobilize all the women to the health facility, our healthcare system will likely crash. So we are using data to inform how we are strengthening the level of care, the quality of care at all levels. We are looking to support state-level data-driven planning and coordination. Our states need to own their data, work with it, and use it to inform the work they do, of course, while synchronizing with the national. Cross-partner coordination platform is to sustain alignment and accountability is one thing we are looking to do. Because we know all the partners still need to see their data as the property of the government that we help them to take decisions with. And lastly is to advance equity-focused approach by ensuring that underserved population are reached with the high-impact intervention. The quality of care any woman or child will get should not be determined, influenced, limited by where you live, how much you have, or what you have access to. And those are the things we are doing. So my final word will be to invite all the stakeholders, government partners, practitioners to continue to use available data to prioritize the highest impact intervention. We should always collaborate more intentionally to reduce fragmentation and scale what works. There is no need for us to reinvent the wheel. For every time we get into a community to work, can we all look at what already exists and now we can plug in? And when we are living as well, can we also leave our footprint by dropping all of the data we've worked on and ensuring that it is so clear, easily replicated, visualized clearly, with some clear plan on how they could be used. And we need to invest more in the systems that ensure data is accessible, interpretable, and actionable at all levels. And with all of this, I believe we can build a stronger, more responsive maternal and newborn health system that saves lives and ensure no woman or newborn is left behind. We know them, we reach them, and they have the potential to live quality life. So I will pause here and thank you all once again for joining today's webinar. It's been quite amazing having you all on this. And we look forward to welcoming you on subsequent editions, collaborating more, listening more, and taking all of these lessons forward as we act. Over and out from Chidera. Thank you once again for having me.
Thank you so much, Afiz. I mean, these priorities resonate strongly with everything that we've just said today. That brings us to the close of today's webinar. I want to begin by sincerely thanking all of our three speakers, Nanman, Dr. Buka, as well as Dr. Yahaya. You not just brought your expertise, you also brought your genuine experience into this conversation. Thank you so much. And to every participant that joined us today, I mean, you asked your questions, you voted on the poll, you engaged with us using the chat bot. We are exceptionally grateful. And you are the exact kind of audience that we are looking for to make this conversation worthwhile. Thank you so much.